lovely workshop on the updates to the tobacco products and electronic delivery systems control bill. My name is Melissa Zyman. I'm the marketing and social media coordinator at CANSA, and I've come to help the team today. You've done an excellent job in putting this event together. So thank you very much for joining us. We have some lovely, informative topics being discussed today. And to kick us off this morning, I'd like to introduce you to my colleague, Lorraine Govender. She is the National Manager for Health Programs at CANSA. And Lorraine, thank you very much to you and your team for this excellent event.
Good morning, everyone. Welcome and thank you for attending this important workshop on the tobacco control updates. It is truly a privilege to be with each and every one of you here today in Cape Town. Pity that we've got a bit of cold weather. I think we brought the rain from KZN. Okay. Today we'll be diving into updates on the progress of the Tobacco Control and Electronic Delivery Systems Bill, some of the latest research that will help you understand why we need this bill. Our goal is to provide you with valuable insights, evidence-based updates, and practical approaches that can drive real impact in our communities. And that is why it's so important that today our audience, which we normally are used to having academics and researchers and all the professional people, but today, yes, we have professional people here in our audience as well as people from our communities in Cape Town. Most of you have been part of our tobacco public bill hearings. You've been there, you've witnessed it, you've spoken, you've aired your voices, and we will give you updates on what else is to come. So this is a very collaborative space, so I encourage you to ask questions, share experiences, and engage in discussions. Together, we can strengthen our efforts and continue to make a meaningful progress in tobacco control efforts. Let's get started. Thank you.
My name is Minete Damini, and I'll be taking you guys through some of the various legislative processes that the bill has undergone so far. And also I'm going to be talking briefly about the next steps, what should we expect from now on going forward. So, just to remind ourselves, here we are talking about tobacco products and electronic delivery systems control bill. In our country, we do have the current existing tobacco law, but this new bill, its main purpose is to try and address the aspects that are currently not covered in the current existing tobacco law, and also close all the gaps, such as regulation of the newer products that are making our young people starting to engage in some of these risky behaviors, such as smoking. So, when we speak about the products that are going to be covered in this new proposed bill, these are the products that we're speaking about. It's going to include traditional tobacco products, your newer products as well, as I mentioned, such as vapes, your heated tobacco products, your non-combustible products, including the mentioned products such as your nicotine pouches. So I'm going to take you guys through some of the various legislation processes that the bill has gone so far. The bill was formally introduced in 2018, but I'm going to jump and start in 2023. So in 2023, the bill was formally introduced in Parliament during the World Non-Tobacco Day by the former Deputy Minister at the time. His name is Dr. Siphoniseni Dlomo, and he's now the new chairperson of the Portfolio Committee on Health. And then same year, in July, the bill was then advertised for public comments, where the Parliament invited all the public community members, relevant stakeholders to basically make submission and write to the Parliament voicing their opinion about the bill, where they needed to say whether they're in support of the bill or against the bill. If they were in support of the bill, they needed to say why they are in support of the bill, and if they were against the bill, they needed to specify and say why they are against the bill. And then in August, the Portfolio Committee on Health announced that they're now going to be visiting all the 9 provinces to basically give now the community members an opportunity to come and present to them again their opinions about the bill, similar to the written comments, but now we're going to do the oral presentation. So that whole process started in August in the Northwest Province, where we visited 3 different districts, which were Rustenburg, Mahikeng, and I forgot the 3rd district. So in conducting the public hearings, the Portfolio Committee on Health, they selected 3 districts per province, and they ended up covering a total of 27 districts, which were concluded this year on the 1st of February here in Western Cape in George. So in this picture here, these are some of the pictures that were taken during the community public hearings. So in these hearings again, everybody over the age of 18 years participated, including young people, the youth, elderly people, community leaders, professionals, and including the industry as well, the people that are creating these tobacco products. So currently, the bill is still in Parliament. Since now they've concluded with the community public hearings, the bill has moved to the parliamentary hearings, which commenced on the 19th of March. So the parliamentary hearings are all, the people that go there and present are the people that make the written submissions. So when you made the written submission, there was a section there that asked if you'd like to enforce your submission through making an oral presentation during the parliamentary hearings. So everybody that indicated that you'd like to enforce their submission during oral presentation is now going to be invited to Parliament to make the oral presentation. So all the parliamentary hearings are going to be conducted virtually via Zoom. So currently at the moment, the hearings are done, conducted on Wednesday, every Wednesday from 10 to 1 o'clock. So everybody that will be invited is given 7 days, it's told 7 days in advance that they're going to be to present in front of the Portfolio Committee on Health, and then they giving a link as well for the Zoom meeting. The reason these meetings are conducted virtually, the Portfolio Committee mentioned that it's going to be difficult for everyone to travel across different provinces to come to Cape Town for these hearings. So that's why they propose that this hearing should be conducted virtually to make it accessible for everyone across the whole country. And then from here, the bill will now move to the National Council of Provinces hearings. So this is the stage now. It's going to be similar to the community public hearing. The bill will go back again to the provinces, but now this will be run by the National Council of Provinces, where they again inviting people, relevant stakeholders to come and present before the provincial leaders on the bill. And then if this bill passes in the NCOP, then it will go to the President for the assent and signature. The then if the bill is rejected in the NTOPs, it will go back to the National Assembly again for amendment. We are hoping that this whole process, the bill will eventually pass through the NTOP so that we can avoid it going back to the National Assembly again for amendment. But should that happen, this is the process that the bill will follow. So I know that some of the people that are here with us might not have an opportunity to make the written submissions. As I've said, they're still going to have an opportunity to come and present again during the provincial hearings. And as I close, I would like to leave you with this quote. This is one of my favorite quotes that says, you can have 1,000 problems in life until you have a health problem. Then you only have one problem. So this bill is very crucial in our country as it will help us save lives, reduce tobacco use, protect our young people from getting addicted to some of these harmful tobacco products, and also protect the vulnerable population from being eventually exposed to tobacco products. Thank you.
Thank you, Monique. That was really great to hear about the updates on the bill. Next, I'd like to introduce Dr. Samantha Philby. Samantha is a research officer at the Research Unit on the Economics of Exercise Products, or also known as REAP, at the University of Cape Town, where her work focuses on the economic aspects of tobacco, alcohol, and e-cigarette control policies. She was awarded a Fulbright scholarship to support her PhD research, which explores the economic aspects of tobacco control policies. At REAP, Sam also serves as a program manager of the World Health Organization FCTC Knowledge Hub on Tobacco Taxation, contributing to global policy efforts. In addition to her research, Sam also lectures undergraduate economics at UCT. Thank you for joining us.
Good morning, everyone.
Good morning.
It's absolutely fantastic to be joining you this morning. My name is Sam, and I will be speaking to you about some research that I took part in about e-cigarette use among high school learners in South Africa. Just some acknowledgements at the start. The research I'll be talking about was a big team effort. The study that we ultimately published was led by Professor Richard van Zyl-Smith from the UCT Lung Institute, and joining myself as a co-author was Dr. Gervin Swan, Dr. Jacqueline Hall, Asya van der Bosch, and Sebastian Curtin. So just to acknowledge my co-authors on this project. As some background to our study, a 2023 World Health Organization call to action highlights that the promotion of e-cigarettes has led to a substantial rise in their use by children and adolescents. So in the USA, e-cigarette use among high school learners has been declared an epidemic. And in countries like the UK, around 21% of young people have reported ever using an e-cigarette, and around 8% of learners in the UK currently use these products. A global study using data from 75 countries estimated that around 20% of young people aged between 13 and 15 have ever tried an e-cigarette, and that the proportion of young people in these 75 countries currently using these products stands at 11%. Unfortunately, in the largest study to date about the number of young people using e-cigarettes, South Africa was excluded. The reason for this is that South Africa has not conducted a global youth tobacco survey, which is a mechanism for monitoring young people's tobacco and novel tobacco use behaviors, since 2011. And even in our 2011 survey, so more than a decade ago, our young people weren't asked about whether they use e-cigarettes or not. So in this context, where we felt that South Africa was kind of left out of the global equation of what's going on with young people's novel tobacco product use, or e-cigarettes, we decided to try and investigate it. So what we did was we developed a survey to study e-cigarette use, and not only e-cigarette use, but also levels of dependence on e-cigarettes among the young people who currently vape. We also wanted to understand what factors are driving young people in our country toward using these products. So to kind of develop our research protocol, we approached 90 schools in major centres like Cape Town, Joburg, Pretoria, Durban, as well as smaller centres like Bloemfontein, Pietermaritzburg and East London. To try and locate the schools that we were going to include, we went to the National Department of Education website and also the National Schools Association network to try and ensure some degree of fee variability between the schools. We wanted both high fee schools and lower fee schools. And we also wanted variability in the types of schools that we drew our samples from. For example, co-educational schools where girls and boys are mixed, and then single-sex schools that accommodate, say, just boys or only girls. It's important to note up front that a limitation of our study is that we only selected schools in the fee-paying quintiles. So the National Department of Education divides all the schools in the country into 5 different quintiles. Schools in quintile 1 are the least well-resourced, and schools in quintile 5 are the most well-resourced. In the country, in our country, schools in quintiles 1 and 2 are non-fee paying schools. In other words, the government is providing the support for those learners to attend schools. And schools in quintiles 3 and up are all fee paying schools, but they receive various degrees of subsidy from the government to contribute toward those school fees. We were not able to include schools that did not have internet access in our survey or non-fee paying schools because our survey was done by users on their mobile phones. So just important to note up front. Overall, of the 90 schools that we approached, 52 agreed to participate. That gave us a sample of around 25,000 young South African students currently attending high school. In terms of what our sample looked like at the school level, about 17% of students in our sample attended what we classified as lower fee schools, receiving some form of government support. 64% of pupils attended medium fee schools, and 19% of the students in our sample attended high fee schools. That's where they're paying over 90,000 rand a year in school fees, and typically these learners were attending boarding schools, which explains the kind of exorbitant cost. In terms of what our school type breakdown looked like, in terms of the gender of the learners accommodated at the school, about 31% of the learners were in co-ed schools, so boys and girls were mixed. 41% of the learners in our sample attended all boys schools, and 29% attended all girls schools. So outside of this kind of big school level picture, which we knew, we targeted these schools and we went to talk to learners in those selected schools, we asked students about some of their demographic information. How old are you? What grade are you in? How do you identify your gender? In addition to that, we gave learners 3 10-point Likert scales. So we said, on a scale of 1 to 10, how would you rate the following? Firstly, we asked them, what is your ability to concentrate when you're studying like? We also asked them, how stressed do you feel about school or about life? And we asked them, how harmful do you believe vaping is relative to tobacco and cigarettes? So in terms of what our learners look like, here's giving you the percentage of the learners in the population in each group. We had a pretty even split from grades 8 to grade 11, just shy of 22% of learners in our sample were in those grades, and a smaller proportion, around 13%, were in matric. Schools were quite protective of letting us talk to the matric learners because many of them were preparing for the third term exams or the final exams, so they didn't want us to interfere with them too much. In terms of what the gender of the students in our sample was, about 46% were girls, just over half were boys, and just over 2% didn't want to identify with the binary gender. Just less than 1% said, I feel transgender, and 2.1% said, I don't want to identify. In terms of students' feelings about their ability to concentrate, in our sample, about 55% of students reported a below average ability to concentrate. I really struggle to focus when I'm studying. Most students in our sample, about 80%, said, I feel really stressed about school or life. And in terms of how harmful they perceive vaping relative to tobacco, most students, about 56%, said, I think they are as harmful, as bad as tobacco. But we do have varying degrees of students saying, I don't think they're as bad as tobacco, or I think they're actually less harmful than tobacco products. So with this kind of background demographic information in mind, what gender they are, what grade they're in, how old they are, what kind of school they're in, we wanted to ask these students some things about their product use. So we investigated students' usage of 4 different products: e-cigarettes, tobacco cigarettes, cannabis, and hookah pipe. Because we were pretty focused on closing what we perceive to be a gap in knowledge around youth vaping among young people in South Africa, we asked learners who told us that they vaped extra questions. Specifically, we asked them about their vaping history. When did you start? We also asked them about their vaping habits. Do you use a nicotine vape or a non-nicotine vape? How many days a week do you vape, etc. We also wanted to gain insight into the reasons why learners start to vape. So of those students who currently said, I vape, we want to know, why did you start? And not only that, we also asked them, if you started, why did you continue? Using the data that we collected, we studied e-cigarette use, what we call vape dependence, as well as the factors associated with vaping among a large sample of South African learners, that plus minus 25,000 students that we spoke to in various schools. So what did we find? In the 30 days before the survey, so our framing was, in the past 30 days, have you done question X? So what we found is in the 30 days preceding the survey, just over 36% of learners reported having ever tried a vaping product. That was over the course of their lifetime. Then in the 30 days preceding the survey, just shy of 17% of the 25,000 students in our sample reported that they currently used a vaping product. In other words, in the past 30 days, I have smoked a vape. What we observed, quite strikingly, compared to what we've seen with youth substance use in the past, is that there were far lower rates of tobacco cigarette use, cannabis use, and hookah use relative to vape use. Specifically, only 2.1% of the learners that we sampled reported that they currently smoke tobacco cigarettes. Only 5.1% reported that they'd smoked marijuana recently, and only 3.2% had reported smoking hookah pipe in the 30 days before the survey. This is substantially lower than the 16.8% who told us that in the 30 days before the survey, they had used a vaping product. So vaping seems to have taken over amongst our young people as their product of choice. What this graph is showing is the percentage of students in each grade. So we took the 25,000 students. These little dots each represent individual schools. The half-colored dots represent co-ed schools. The clear dots represent all girls schools, and the full-colored in dots represent all boys schools. So we kind of took the 52 schools and said, how does vaping vary by grade across the different schools? And what we found was quite striking. Firstly, the proportion of learners that use e-cigarettes increases by grade. Specifically, what we see is amongst grade 8s, around 9% of grade 8 students, that's people who are between 12, 13, 14 years old, reported using e-cigarettes. If you go up to matric, the average number of students using e-cigarettes in our sample, if they were matric, is as high as 29.5%. What we also observed, these dots are basically showing the proportion of learners using e-cigarettes in each school by grade. You can see that among grade 8s, it's more squashed together than it is amongst matrics. The shapes are more spread out. What this dot is telling us up here is that we actually visited a school where 46% of the matric class were currently using e-cigarettes. That's half of your matric year, people who are set to be 18, had used an e-cigarette in the recent past. So going beyond this kind of descriptive analysis, which paints quite a troubling picture for us as researchers and as people interested in public health, we wanted to get a little bit more sophisticated than just describing the data with pictures. So we ran a model to try estimate or determine what factors influence the likelihood that a learner is using a vape. In this model, we controlled all the data we collected, how old the student was, what grade they were in, whether they were a boy or a girl, or they chose to identify with a non-binary gender. We also controlled for what they told us about how they feel about stress, how they feel about their ability to concentrate, and we controlled for how harmful they perceive vaping to be relative to cigarettes. In addition to these kind of individual level things that vary by student, we also wanted to control for the school fee bracket they were in. So we wanted to use the amount of money that their parents are paying for fees as a proxy for the family's income. Maybe vape use varies by how wealthy you are or not. So we tried to test for this. In terms of looking at this table, the blue ones I've highlighted here, if you run across the row, are all the factors that we say significantly affect the likelihood of vape use. So what we found here is that in terms of the factors that we control for, the odds of vape use rise significantly with age and also by grade. And in fact, relative to learners in grade 8, the odds of vape use, or the likelihood that a learner is a vape user, is significantly higher among matric learners than it is for learners in any other grade. But regardless of what grade you're in, compared to a student in grade 8, as you move up through your schooling career, you are more likely to be a current vape user. Interestingly, we found that gender identity wasn't significantly associated with the odds or the likelihood that a student is a vape user. We did find, however, that students reporting an above average ability to concentrate were less likely to use vapes than learners who reported a below average ability to concentrate while studying. Also quite striking and quite important on my point of view from a policy perspective is the fact that the perceived harms of vaping relative to tobacco cigarettes seems to influence young people's decision-making around vape use. Specifically, we estimated that if a learner perceives vaping to be harmful relative to tobacco cigarettes, they were significantly less likely to be a vape user than someone who said, I don't think vapes are really that harmful. Actually, they might not even be harmful at all relative to cigarettes. So learners being informed of the fact that vaping is not harmless is an important determinant of their decision to use these products or not. And that speaks to the education aspect and the role of the legislation that's coming up in informing young people that this is not an okay thing to do for your health. Lastly, just worth highlighting what we found very interesting was that the school fee bracket was not significantly associated with the likelihood that a learner used vapes. In other words, given that our sample was restricted to students in fee-paying schools, it basically tells us if your parents can afford for you to pay your school fees, you can afford access to a vape. That was a sample that looked at all 25,000 students. Remember, we were just trying to determine what influences the likelihood that a young person is going to vape or not. Then we really wanted to focus in on the learners who currently vape. And among those learners, we were specifically interested in identifying indicators of addiction. So what we did was we tried to collect information on learners' vaping habits to inform our understanding of the extent to which these young people are dependent on vapes. They're vaping. How addicted are they? How much of a problem is this? So to this end, we asked students about their average vaping intensity, i.e., how many days a week do you vape? 1 day a week, 4 days a week, every day of the week? We also asked them, how long do you wait between waking up and the first puff you take of your vape? Do you wait less than 5 minutes? Do you wait more than 5 minutes but less than an hour? Or do you at least wait an hour between when you wake up and have your first vape? We also asked students, can you get through the entire school day without vaping? Yes or no? We asked whether they report or whether they feel anxious or angry if they're delayed in vaping. If I can't vape right now, do I start to get like itchy? And finally, we asked them, do you use a nicotine or a non-nicotine vape? Remember, these are indicators of addiction for us. We want to understand, are the kids who vape, how addicted are they? Based on this, we estimated that around 30% of our learners in our sample vape every single day of the week. That's high school kids vaping every day of the week, and more than half of the learners in our sample reported that they vape 4 or more days per week. Most disturbingly, around 88% of the learners in our sample use vapes that contain nicotine. 47% of the learners in our sample reported that they vape within the first hour of waking up. 12% indicated that they can't get through the school day without vaping, and 25% indicated that they start to get scratchy if they have to wait a long time before they can vape. So we asked them these questions, and now we wanted to use them to measure something. We wanted to build a scale of dependence how can we measure how addicted these students are based on their responses? And so we developed 2 dependence scores. The first dependence score went from a score of 2 to 10. And we took the average number of days that a student reported they vaped each week. We gave them a score of 1 if they vaped on 1 day per week, a score of 2 if they vaped 2 days per week, up to a score of 7 if they vaped on all days of the week. To that number, we added the time from waking to first vape use. For learners who told us they wait at least an hour between when they wake up and their first vape, we gave them the lowest score of 1. And learners who told us that they vape within 5 minutes of waking up, we gave a score of 3. So for example, if a student told us they vape all days of the week, 7 days a week, they get a 7. And if they told us they wait less than 5 minutes, we'd add 7 plus 3 to get 10, the maximum score. On the basis of this score, we measured that around 58% of students in our sample are highly vape dependent. In other words, we look at the range of scores, we take the middle score, the middle between 2 and 10 is 6, and we say learners with a score above 6, based on the number of days they vape each week and the time they wait between waking up and vaping, over half, nearly 60% of the learners in our sample are highly vape dependent. We used a more sophisticated measure, so we started with the basic one, which used number of vaping days each week and time from waking to first vape use. And to that, we added additional complexity. We added a measure of whether the student could complete the school day without vaping. So they get a 1 if they can't, because that's more addictive behavior, and a 0 if they can get through the whole school day without vaping. Similarly, we gave them a score of 1 if they said, I do feel anxious or angry if I can't vape when I want to, and a score of 0 if they don't. And lastly, we gave them a score of 1 if they use nicotine vapes, and a score of 0 if they don't. This score ranged between 2 and 13. We took again the middle score, which is 7.5, and we said, okay, based on their self-reported vaping behavior, learners with a score above 7.5 are classified as highly vape dependent, and learners with a score below are classified as less vape dependent. And on this more sophisticated metric, we found that about 61% of the vape users in our sample are highly vape dependent. The final aspect of our research concerned the reasons why adolescents start and continue to vape. If we're going to be developing interventions to help young people, we need to understand what gets them here in the first place. So specifically, we asked learners to respond to the question, why did you start to vape? We gave them some predefined response options, and then in response to why do you continue to vape, we just let them write. Why do you carry on vaping? We got a bunch of written answers from the students, and we try to group them into categories. Students write different reasons, and some of the reasons mean the same thing. They're very clever programs that can help us as research gain insights into students' qualitative or written responses. So for example, we created one category called emotional well-being, and a student would have fallen in there. They said, I vape because it helps me cope with my problems, or I vape because it makes me feel less stressed, I vape because it helps me relax. And that was kind of the framework we went through. What this graph is telling us, on the left-hand side, we have the reasons for starting vaping. The top reasons learners told us that they started to vape was due to social influences. So for example, I vape because my friends vape, or I started because I was at a party and I felt left out. More than half of the learners in our sample started vaping due to social influences. The second most cited reason for why the learners who vape in our sample said they started was for emotional well-being. I started because I wanted to manage the stress and anxiety I was feeling, or I was feeling a bit down. And then the third most cited reason is this notion of enjoyment and exploration. I was curious about the flavors. I wanted to know what it tastes like. On the other side, we have the reasons they gave from continuing. And the nice thing about this kind of figure is it helps us map how the reasons for starting transition to the reasons for continuing. And the most striking part of this study for me was that although more than half of students, about 52%, said they started for social influence reasons, less than 10% continue for social influence reasons. Here it's 8.18. So if we match those who started from peer pressure or the need to fit in, less than 10%, 8.18% said that's the reason I continue. Much more commonly, users were saying the reasons I continue is because I like the feeling, the physical sensation. Many learners cited the head rush that they get from vaping. Another reason was learners using this as a crutch for emotional well-being. And what was promising for us was that at least 15% of students gave us the third most cited reason why they continue. I'm addicted. From the students who started due to social influence, they transitioned down. About 17% of these kids moved down to the reason I continue, even though I started because my friends told me or I wanted to fit in with my friends, continue due to a high level of dependency of these products. Many of the kids who started for reasons of emotional well-being also continue because they acknowledge their addicted. So while we find it promising that young learners are able to at least identify their addiction, a striking finding for us as researchers was that around 46% of the learners did not list addiction as the reason why they continue. They said rather, I'm using it to cope with stress, or I'm using it to cope with anxiety, or just to chill out. But when we look at the vaping behaviors of these students who gave us some other reason why they continue, they exhibit behaviors of someone who is highly addicted. And we had a psychiatrist on our research team, and she taught me a term in this thing. She says this is cognitive dissonance. Learners being divorced from their reality. They think they are using vapes to just chill out, but in fact they are unaware of the fact that they are addicted. And that speaks to the importance of informing young people of what addiction is, what it means, and the adverse health consequences that it can have for you, and how it may not necessarily be a coping mode. We're on to the what can we do to translate these research findings into evidence. First port of call, the South African government must pass the Tobacco Products and Electronic Delivery Systems Control Bill. This bill will restrict young people's access to vapes. It is unacceptable that around 17% of 25,000 learners were able to vape in the 30 days. Where did they get these vapes from? That needs to end. The bill will also restrict advertising of vaping products, which aids in the de-glamorization of vaping among young people. This is pivotal for reducing the general curiosity that leads many young people to start in the first place. We have the data. The third most cited reason why young people try vaping is because they are curious. They are curious about the flavors and they want to know what it feels like. The dangerous myth that vaping is safe also needs to be debunked. Of course, basic education around the harms of vaping will be important, and our own model results, our own data from our own country tells us that when learners don't believe that vaping is harmful, they are more likely to be vape users. Given that we saw how vape use increases by grade, but it is still around 9% among the sample grade 8 learners, that's not acceptable. It is clear that these kind of education and preventative measures will need to be implemented at younger grades. Anecdotally, I received a request from a journalist in East London who informed me that in a school there, teachers were reporting learners as young as grade 4 using vapes at school. So it's not that this is something that needs to wait until high school. This is something that we need to incorporate into the school system a lot earlier, and among parents too. In terms of debunking the myth that the dangerous myth that vaping is safe, restrictions on vape marketing provided for by the bill will also be pivotal in this regard. Look at this picture. I took this off the View's website. How are we not marketing these things as at least healthy? That's fresh, beautiful fruit. It looks delicious. That needs to be done away with instantly. The bill is critical for creating a regulatory environment that de-glamorizes, denormalizes vaping, and restricts young people's access to these products. But a key takeaway from our research that resonated with me strongly was that we mustn't forget about the young people who are currently addicted. Okay, we are not just sitting with it. We need to prevent vaping initiation. We need to get people who aren't addicted to stop quickly and to not think these products are wonderful. But we also need to help teenagers who are currently dependent on these products to stop too. and there's some key challenges that we face in this regard. A recent Cochrane review showed no robust randomized control trial data. That's basically saying there's no studies out there that make us, as this agency that publishes these reports of best strategies for dealing with addiction, there's no existing evidence for us as a review agency to conclude that we know what to do when it comes to deal with young people's vaping behaviors specifically. There is no validated tool for measuring adolescent nicotine dependence. We use the Fagerstrom test when it comes to tobacco cigarette use amongst adults. But the problem is e-cigarettes don't have tobacco, it's nicotine. And typically nicotine is not characterized as a substance use disorder. There are also no approved pharmacological medicines like patches and things for people under 18. Similarly, the kind of behavioral interventions used to kind of counsel smokers, adult cigarette smokers through quitting, have not been validated in the youth vaping context. And so when we're thinking about these young people who are highly addicted, it will be necessary for us to extrapolate from the kind of adult tobacco cessation framework. That's fine. But our effective interventions have to be tailored for the adolescent vaping addiction context. So we need to balance the fact that we have a group of young people who are addicted to nicotine predominantly, and also the unique mental health and social stresses that young people are going through. Lastly, when we're thinking about this, I don't believe that punishing young people for vaping is likely to be the way to deal with this. Rather, we need to identify, engage, and adhere to treatment that will lead to young people's quit success. In this regard, parents must be aware of the signs of vaping and the underlying issues that are driving it. Health professionals should ask young people about their vape use during their routine checkups, like at the dentist, and they can also help young people facilitate adherence to treatment. If you need to go on a patch at the age of 18 because you are addicted to nicotine, a healthcare professional can ensure that you are adhering to that regimen. And finally, we do believe there is role and scope for school counselors to teach young people coping strategies so that they don't feel the need to navigate life challenges using a vape as a crutch. Thank you so much for your time and engagement today. I really appreciate it.
So we would like to, I'll just give a brief introduction of Dr. Bulela Vava from the Public Oral Health Forum. He is the founder and president of the Public Oral Health Forum, a global Atlantic fellow, and a community dentistry registrar at Wits University. With more than a decade of experience in South Africa, in the South African public oral health sector, he has been a strong advocate for health equity, particularly in rural and underserved communities. His early involvement with organizations such as Rural Doctors Association, Section 27, and the Rural Health Advocacy Project helped shape his activism in healthcare leadership and management. As a student, he co-founded the TICS Rural Health Society and at the University of Pretoria to promote rural healthcare careers. Early in his career, he served as the student liaison for RU-DASA and was elected vice president of the South African Dental Association's Young Dentists Council, where he championed the interests of young dentists. While working as a rural dentist in the Bode Eastern Cape, his contributions were recognized by the Atlantic Institute, leading to his selection as a Global Atlantic Fellow for Health Equity in South Africa in 2019. This experience inspired the creation of the Public Oral Health Forum, a member-based organization committed to advancing oral health equity in South Africa. So thank you very much, Dr. Vava, for joining us, albeit virtually. So over to you.
Thank you for the opportunity to actually share what the Public Oral Health Forum has been doing, intends on doing, with partners around tobacco control advocacy within South Africa. Now, I probably just before I start, I just want to take a brief moment to acknowledge, of course, my colleagues with whom I work, those who definitely came before me, whose work definitely does inform my own. But beyond just the oral health community, I probably want to acknowledge communities who are often actually never seen beyond the demands they either put on the state or the health professions at large. But I want to recognize before I start their dignity, their sense of self-sufficiency, and of course, more importantly, their sense of agency and advocacy. Now, Minethe, if you could share, or should I share my presentation? I did prepare a presentation so that I could just synthesize my thoughts and have this conversation in a more structured manner. So I will try and share it from my side. I would hope that I'll be allowed to, because normally it never happens that way.
We can see it.
Can we? Okay, are the slides moving?
Yes, they are.
Great, thank you so much. Let me just remove all these Zoom things all over the screen. Let it just obstructing my view. And let's just dive in. I'm not really going to waste any time outlining what I'm trying to do, but it's pretty much just a little bit of highlighting why this particular issue of tobacco control within the South African context is particularly important for the oral health community, but not just the oral health community, but the communities that we actually serve. Beyond that, we will look at what I would think that some people in the room and those online probably know very well, issues around prevalence, and also just looking at what we are trying to do and what we have been doing. Now, there we go. Now, one thing that's particularly very important for us to know is that the use of tobacco products has a direct impact on oral health. And this has been demonstrated in many instances in the development of gum disease, which of course leads to tooth loss in some instances, or in many circumstances actually, and of course oral infections. Particularly one of the most very obvious signs is glaring staining of teeth and bad breath in those who do smoke. There is, of course, delayed healing, in particular after dental procedures like the removal of teeth. I'm sure for those of you who've gone to actually have a tooth removed, your therapist or your dentist has said to you, please just remember not to smoke. Please do not smoke for a certain period of time, and that's because tobacco, smoke, and tobacco itself, and the components within tobacco products have result in adverse surgical outcomes. It's also important, of course, I think for the sake of the conversation, we are having an organization that has brought us into this room together, that tobacco use really contributes significantly to the development of oral cancers. And lastly, there is reduced salivary flow, which is basically the reduced amount of saliva already in your mouth. Decreases because you take up smoking, and what that does is that it creates a very dry environment. Your saliva plays a very important cleansing role, and that cleansing function that your saliva plays in your mouth, it's not just to moisten the food that you eat so that it goes into your body much easier, but what it actually does as well is that it serves as a cleansing and a cleaner of sorts, which also kind of assists with fending against certain dental diseases, in particular in this case, dental decay. Now, of course, what we at the Public Oral Health Forum really truly represent is a voice that calls for the integration of oral health. We are calling for the return of the mouth back into the body. So it is very important for us to understand that what happens, and I'm going to touch a little bit about this, that what happens in the mouth actually also impacts what happens in the body. But it's just important for those who already know, of course, there's been research papers, there have been campaigns already run about the impacts of tobacco use on cardiovascular or heart health. We all know the link between tobacco smoking and actually respiratory diseases in the form of lung cancers, and of course compromised immune function. And again, because people use these tobacco products, they are definitely at increased risk of developing other various forms of cancers because of the carcinogens that are actually in these products. Now, it is important to understand again that oral health is a mirror to some extent of overall health, and issues that occur in the mouth can definitely signal and contribute to broader general health problems. Now, just a little bit about oral cancer within our context within which we approach, we function of South Africa. Oral cancer accounts for a significant portion of health and neck cancers in South Africa. And you will see, of course, I'm not playing around with a lot of numbers because we'll talk about this in my later slide. But there's a deliberateness in the omission, I guess, of the percentages. 60%, for example, of head and neck cancers are related to oral cancer, for example. We are missing out that kind of information for a reason. But it's important for us to also understand that, as I alluded to before, that tobacco use, alcohol consumption, and HPV infection actually are some very important risk factors. These are not the only risk factors, but these are very significant and important risk factors for the development of oral cancers. What then, is there somebody trying to say something?
No.
No, all good.
Oh, okay, no, thank you. So what's particularly important for us to know is that there's definitely a high prevalence of oral cancers amongst disadvantaged communities, and in particular those with limited access to healthcare services. The late-stage diagnosis that is informed in certain instances by beliefs, by the lack of awareness and limited screening programs in some communities, contribute significantly to the picture of oral cancer within our context. And like anyone else, treating oral cancer is extremely costly. And these high treatment costs pretty much are a huge driver in an unequal society like South Africa of one, seeing the high prevalence, but also the lack of access to these services, in particular specialized oncology care, which also comes with the set of interventions that are required to actually respond to these diseases. That it's missing on my slide, but I'll just share with you. We have about 62 million South Africans, by estimate, living in this country, or 62 million people living in this country. And when we look at the amount or the number of oral healthcare professionals who work in this country, that number is no more than 14,000. And of that group, you only have less than 7,000 dentists who have to play a very critical role in the early detection and intervention in many of these cases. And of that same 7,000, less than 2,000 of them are actually working for government. And even within those who work for government, they are unequitably distributed, with the majority of them in the big metros. So you kind of get to see how dire this picture actually is, in particular for the early diagnosis, and even for screening campaigns in relation to oral cancer. Now, it is important for us to note that there are limited resources for early and accurate detection, which is what I kind of was alluding to. And these are contributing, of course, to an inconsistent picture when it comes to data on oral cancer. An example of this, for example, is there is severe underreporting. And this is largely because of the classifications of cancers, and even within the head and neck cancers, various classifications that apply. But an example is if someone actually comes to a healthcare facility with advanced oral cancer, as an example, it may have started in the mouth, But now they are struggling to swallow, as an example, and now they decide, let me go and actually present at the hospital because I'm struggling to swallow and eat. What often happens, for example, is that that moves away from a diagnosis in many instances of an oral cancer, although it started and manifested in the mouth, to it being called maybe a neck cancer or some other category within the ENT medical specialties. Now, how we categorize or how we diagnose and categorize these cancers is particularly important for who gets to play a role in the response. And my last point is to also kind of highlight this aspect that there are definitely inequitable oral cancer outcomes, and these are linked to socioeconomic and demographic factors. The oral cancer picture is very different for the Eastern Cape versus Gauteng, for a very remote village in the Eastern Cape and Pimville in Soweto, or Parktown in Johannesburg North. Those pictures where a person lives and the conditions within which a person lives directly influences their susceptibility, or perhaps whether or not, in terms of those who are diagnosed with cancer, what their prognostic picture, likelihood of survival, and without using these technical terms, their likelihood of survival varies across these different social and economic demographics. So it's obvious that there's definitely a need for very strong advocacy. We are appreciating, of course, that there is a high prevalence of tobacco use, and despite the risks that we've mentioned, there is a big problem, which is a newfound problem, but a big problem of this emergence of these alternative tobacco products, which are highly unregulated and are particularly popular amongst the young population because of the direct marketing approaches that these unscrupulous companies are using. And what this means as well is that we are more likely to see they are creating new customers for the future, basically. So we need to intervene, and we need to intervene urgently. So as far as, again, what advocacy goals apply in this particular scenario, it is important, of course, what is happening now with the Tobacco and Electronic Delivery Systems Control Bill. Very long. That work that's happening there needs to be advanced because it aims to, of course, implement stricter tobacco control policies. Let me just switch off the seeing things here, sorry, that are making me unable to see what I need to see. In addition to this, it is important, of course, that we increase public awareness about the risks associated with all forms of tobacco. And I can't see my notes now, so sorry, just give me a moment. I want to remove the transcription. I don't know if you can remove it on your side, but there's a transcription that's hiding my slide. But I'll move on. So, in the interest of time. So there are, of course, some evidence-based strategies that have been used over the years. And CANSA, for example, and us as an organization have been employing some of these, and other organizations as well have been employing some of these. And again, whether it's us, whether it's the state, whether it's clinical bodies, but in one way or the other, we are involved in using or deploying any of these strategies. One of which, of course, is what we just talked about, the enforcement of higher taxes or related products, stricter controls on marketing and sale and usage of tobacco, health education and promotion programs, community workshops, and I want to spend a little bit of time just sharing this. I think this is something we don't talk about. Whenever we talk about community engagement in the civil society space, and in particular in the healthcare space, we always talk about communities as beneficiaries. So communities must be in some setting, in a clinic, in a hall, and we go there, we give them a whole bunch of information, and we think that we've done our job, which is actually no further from the truth. At the organization, what we are truly trying to do is also reframe our thinking around communities. The acknowledgement I made at the beginning was quite deliberate, because we recognize that communities have agency. And I think for many of us, we realize that in many cases, it's a matter of activating that agency and transforming it into some form of action. And action should be meaningful, not only to the beneficiary, but it should be meaningful to the communities themselves that we engage in this kind of work. So we believe in these community-led initiatives, community-led journalism, community-led research and monitoring. How do we leverage them as partners, not as research participants, but as partners in the pursuit of evidence-based research, and also provide them with the necessary skills in order for them to carry out whole-face, community-based monitoring of what's happening around tobacco, what is happening around the behaviors, what is happening around access to services for conditions linked to tobacco. Communities have an active role to play in that, and therefore as organizations and as healthcare professionals, these are things that we need to look at and reframe, and see how we can actually bring communities into our spaces as collaborators and as people who have agency, who also want to act on what they see happening in their own communities. Needless to say, it is important that we look at the innovative use of digital platforms, not only for wide reach, but also actually to support some of these things that we've mentioned, for education, for research, and for monitoring. These are important things that are needed as we seek to do this kind of work. Now, what we have been, is there someone trying to say something?
No.
Hello?
No, it's all good, Dr. Baba. You can continue.
Okay, no, thank you very much. I thought I had a minute left. I'm only halfway. So, needless to say, it is quite important that as the Public Oral Health Forum, we are a new kid in the block. We're only about 4 years old. We're trying to find our way in making a meaningful impact in society's general and oral health. Now, what's important is that an example of this is we've actually embarked on our first campaign last year, where we commemorate April as Oral Cancer Month, and that's in line, of course, with an international practice to do so. And we decided there's no work around oral cancer awareness in South Africa, and this is a gap that we need to actually start engaging in a space we need to start engaging in. So we were involved in advocacy efforts and awareness campaigns. And the intention there was we hosted a series of educational workshops and seminars where we were talking about various aspects of oral cancer, including diagnosis, management, including lifestyle changes and health promotion in relation of preventing, of course, the development of oral cancers. What we are, of course, looking at doing in the future and in the present actually is working with our partners to kind of put this information around oral cancer out into the public domains. We're looking at doing more writing, more opinion pieces, more research. But again, what is most closer to us is the idea of capacity building initiatives for early detection and cessation. With, again, the very limited oral healthcare community that we have, we realize the limitations of those people being able to reach the wide and far corners of South Africa, to be able to conduct screenings, to be able to provide education. And therefore, we are looking at strategic and developing strategic partnerships to kind of expand this capacity building initiative for appropriate self-diagnosis, what to watch out for, what to look for, what are the signs and symptoms, and also to empower our own colleagues in this space to be very effective in the management of cases of people who present either because they self-diagnosed at home or self-assessed and felt that I need to go and ask if this is something to worry about, and actually make sure that those people are managed well in the continuum of care, beyond diagnosis, referral, and of course, hopefully, appropriate surgical intervention, and after that, hopefully seeing them living cancer-free lives if they were so diagnosed. And again, the role of community awareness is very important, and we need to rethink, and we are in our own within the organization trying to figure out what does a different kind of community awareness look like, because we don't just want to provide information that people will do nothing about, but how do we package it in such a way that it's engaging, it's relevant for the varying contexts where these awareness campaigns will be hosted, for example. What is important and what brought me even to this particular engagement and to this particular meeting is, of course, an appreciation that it's important for us to work together. The style of approach to cancer prevention, the style of approach to cancer advocacy within our context doesn't help anybody. And therefore, it is important that we work with interest stakeholders to advance the work of oral cancer, cancer broadly, not even just oral cancer advocacy. Being able to share resources and best practices amongst each other, and again, being able to take out of these experiences some case studies, to kind of highlight some of these successes. Nothing hurts in civil society like spending years on campaigns and months on campaigns and never actually taking the time to step back and celebrate where things have actually worked. Now, personal testimonials, also from successful initiatives, are particularly important because people want a personally relatable narrative and story to kind of connect to, and that needs to look at how do we communicate what we are doing in this particular space. And narrative building work and storytelling is very, very important, especially sharing community or healthcare user experiences in order to kind of elevate the conversation around cancer, its impact on individual lives, and also society at large. And I think a huge limitation of current framing and thinking around oral cancer has also, oral cancer and actually cancers at large, is this idea that, they are personal, it's this personal thing that nobody talks about. And I think we need to look at how do we remove it from the personal thing, because it's not a personal thing, it's very public. And in order to respond to these personal, often, of course, devastating experiences for some of us, even within our own families, what happens is that if these experiences are kept in our closed doors of pain, and rightfully so, but however, we missed that opportunity to change the system so that it never happens to someone else, that other people who have a chance are afforded through systemic reforms and opportunity, of course, for them to not suffer what many are currently suffering. And just to wrap it up, it's important, of course, that we appreciate that tobacco definitely poses severe risks to oral and general health. And there are rising cases of oral cancer in South Africa. The research that is out there, of course, outlines the gaps of appropriately, for example, singling out oral cancer and saying this is what oral cancer contributes to the broader burden of cancers in South Africa. Very limited capacities there, but it's a space that the Public Oral Health Forum, with the capacities we have in-house, leveraging the partnerships we have, and the skills and knowledge of our own members, we want to have this conversation, we want to unearth this. And on top of it, it's important that indeed comprehensive tobacco control approaches are taken, and that we appreciate, of course, that they require enforcement beyond the legislation being signed off. They require public education about those pieces of legislation. And beyond that, we need to ensure that things like cessation support for those who want to quit are embedded within primary healthcare programs. If I am there's a new program that government had initiated, I think, not sure if it's still going through because of this USAID issues. However, It's a men's health community program. And if you are then having a men's health program, why are you not embedding smoking cessation as part of those programs? It's not enough to focus on circumcision and HIV infection and TB. Why are we not talking about smoking cessation? Why are we not integrating it into those programs? And again, the power of encouraging community members and activists to participate actively in advocacy efforts cannot be understated. And again, what we call for is for people to support the work that we do, in the same way that we support the work that other people that are doing active work in cancer prevention, in cancer advocacy are doing, much as what CANSA is doing. So these partnerships are particularly important, and we really need to start working together for this. And just as I conclude, I will play a short 1-minute video, and I hope people can be able to hear it in the room. But what I want to just say is that we've been involved, because people are probably thinking, but where's the involvement of the POHF in the current processes that have been happening before Parliament regarding the bill? We've been involved, and actually we're involved in the invitation of 80, who is a partner, together with CANSA, to participate in the public hearings, and we participated in a number of them. And this clip is the closing remarks that are made at the last public hearings, and I hope you will hear the message behind what we say and the need for us to stand up for the communities that we belong to and the same communities that we so love.
The cost and consequences of tobacco lie with the majority of the economically vulnerable consumers who do not only pay their financial health, but their lives and health. It is also worth noting that vulnerable populations spend a significant portion of their limited income on tobacco, leading to economic hardships for themselves and their families. As I conclude indeed, any government with the lives of its people in its hands needs to weigh, in consultation as we are doing here, the benefits and risks that may or may not be attributed to the implementation of laws in the public interest. While we need to forever balance economic interests and those of broader society at large, it remains a challenge. However, we call on our lawmakers to remember there is no price for a human life cut short by tobacco use, and that the most valuable unit of any thriving economy is a healthy and productive society. Thank you.
I used to smoke. I was still young. I used to smoke a lot. And one day it just came like that. I got a pain behind my back, and I went to the doctor, and the doctor told me, right, okay, you can't figure out what's wrong actually with me. So he sent me to Gatesville Medical Center. So when I to other doctor in Gatesville, Dr. Kafour, he was actually the one that was checking me out. And so the doctor told me, right, he diagnosed me with cancer. I said, oh, okay. I wasn't actually afraid of it. I was just thinking like that, it's okay. I just accepted. I just accepted. And okay, most of the people, they think if you've got cancer, it's almost like a death sentence. Okay. So the doctor told me, no, we must keep you in now. And okay, so he took me on the scale. He put me on the scale. Yeah. My weight was 45 kilos. I think to myself, 45, a bag of some meat is more heavy than what I am. But okay, right, I accepted. And right, they keep me in. And okay, right after that, with the progress like that, I went to for chemo. I went for chemo, and from my chemo, I went to radiotherapy, and from the radiotherapy, the final was CAT scan. In my Plattekloof, I went there for a CAT scan. And right away, like I said, most of us, the time when we really think about God is when we're in trouble. We think about Him. But otherwise, our mindset is not there. I think about God. But as I was laying there in the bed, I was just asking, my Lord, my life is in your hands, and it's only you. I said, Lord, reach out your healing hand for me, please, my Lord. And right, he was reaching out his healing hands to me. Right, okay, all of it, right, everything went fine. And right, like my daughter, she was my caregiver. She was looking after me. Right, that was 2017, 2019, okay, before that, 2008, my wife passed away due to cancer. She had breast cancer. Right, 2019, 2017, I had lung cancer. 2019, my other son, he also had breast cancer. But okay, I was stage 4 and my son was stage 3. But okay, so it was for me to encourage him and talk him through the grace of the Almighty. The Almighty helped me, and He can also help you. And right, you must just ask, as He said, you must ask, and He will help you. If you knock, He will open the door. Right, okay, he was doing it like that. By the end of the day, okay, my son also survived. He also survived due to the cancer. But I must also say, give thanks to so I went to the doctor. I said, Doctor, I thank you for what you helping me. He said, no, I must thank you because you helped me. He said, no, Doctor, it's through you, my God, and myself. That's the way I survived. If it wasn't for the three of us, I wouldn't have survived. But okay, through the grace of the Almighty, it see me through to everything. But okay, like most of it, there was other people. There was another lady. I was staying number 7. I was staying in Bontero. I was number 7, Lincourt. She was number 7, Mittencourt. On the same day, when I came to the doctor, she was also the same day by the doctor. And the same day when I went to the medical center, she was also there on the same day. And so they also keep her in due to the same, but okay, she wasn't long. She was say about 2-3 weeks in the hospital. She passed away. So it's also due to cancer. But I mean, okay, like for those, I mean, I can always tell people, you mustn't fear. You mustn't fear. We mustn't fear. There's only one way, and that's through the Almighty that can help us. And we can't ask people for help, and this one going to say, no, I can help you, or maybe today he can give you a piece of bread. Tomorrow I'm going to tell that neighbor, hey, you asked me for bread. And that one say, no, you asked me for this. But if we go to the Almighty, He gives us everything for free. He don't charge us, He don't even talk to the other one, I gave him this, I gave him that, I gave him his life back, I gave him this. I mean, everybody, we get it for free, like the sunshine on everyone. He gave it to all of us. The wind blows, it's raining, He doesn't give it to the certain people, He gives it on the good and the bad. He doesn't say, no, it's only for the good, it's only for the bad. He said, no, you all my children, and He gave it to all of us.
So we'd just like to say thank you for joining us.
Abeda, do you want to join me in the front?
Sorry, I just want to add a little, so I forgot Abeda. Okay, she was also one of the people that helped me. So they had a meeting every Wednesday. Every Wednesday night they had a meeting. So Abida came to me. Abida told me, right, we got a meeting here only for the cancer givers, only for the cancer people. So she asked me if I want to join. He said, no, okay, I want to join. Nazi said, nah, Vida also encouraged me. Okay, the people that got cancer, we can talk to one another because we understand one another. If we talk with somebody that didn't have cancer, they can't talk with you because they don't understand you. But Abida, she was there, and the people we had there, okay, it was almost like sisters and brothers. We were there for one another. They motivate one another, and I mean, I must say thank you for your help, and she also bringing me.
Hi, good morning. Goeiemorgen een en allemaal. Thank you for giving me the opportunity. So I'm Abida, the social worker at the CANSA office in Athlone. I cover the area from Cape Town to Kraaifontein to Atlantis. We have about 15 support groups in Cape Town. There we have Sister Cornelia that runs the Lenteveer support group. We have one in Bonteheuwel at the library once a month. We have at Gatesville Malamed Hospital once a month, the first Saturday of every month. And Toby attended there 5 years ago, and now he's at the Bonteheuwel one. So we're glad to have him back. And then we have in Atlantis once a month. We have in Alces River. All over, you can just contact our local office, and if you can't come, we're starting a virtual support group in Cape Town also. Just contact our office, you'll get all the details. And then also, there's still a lot of ignorance and myths about, no one cancer to come to my house, so don't come with a car that says cancer, or an outfit that says cancer, and we say, if you feel uncomfortable, we can do a telecounseling session with you, You don't have to come to us, we can also come to you, or if you don't want that, we can just chat to you over the phone. So we're there for the cancer patient, we'll walk the journey with you, as long as you have an open door policy that, we're there to help you and we're there to assist you in whichever way we can. And many of them, of the support group members that are here can confirm, that we have walked the journey with their husbands or their sisters or their brothers. So thank you to each and every one.
And I believe those are the type of messages that more people need to hear, like first-hand experience. Because you don't want to be somebody that gets hit by a bus to know you don't like it. So, terrible example. So I'm going to be speaking about a couple of myths that the industry are getting up to. And I was quite surprised how diabolical these people are. They are literally out here to destroy society by adding misinformation to every bit of truth. And we understand how broken telephone works. Somebody tells something and the message just becomes like skewed as it goes along. And I was like trying to cradle something and think like, what's the objective? And I got a few points. I was like, okay, number one, they're undermining public health regulations. They're creating doubt about scientific evidence and rehabilitating corporate image. And out of all of that, just one thing stood out constantly. The bottom line is money. So there's this platform called Easy Equities where you can actually look at how companies are performing. And one of the culprits, big tobacco, known as British American Tobacco, they are making a lot of money. And I was like thinking, how are these people making so much money, saying they care about you, and giving you misinformation, but what is it, like 25,000 South Africans are dying a year? So, with that said, one of the most popular myths that they're saying now is that e-cigarettes are 95% safer than traditional cigarettes. Right now, there's a condition called popcorn lung. And these are, well, first off, thanks for the study on South Africa, but this study was done on American students, and they found out that there are people as young as 13 years old getting popcorn lung. So these are people getting their chest ripped open to try and save them. And the claim is that e-cigarettes are 95% safer and it lacks robust scientific backing. The study often cited for the statistic has been criticized for its methodology and potential conflict of interest. Current evidence indicates that e-cigarettes introduce new toxins and have adverse health effects. So the idea is that once you take your vape and you inhale, there's an element inside the vape that heats that liquid up to about 200 degrees Celsius. And once you inhale it, it goes in as obviously a vapor, but inside your lungs it transforms into an oil-based substance. And that's where a lot of the problems happen. So yes, there are isolated examples of people having smoked for years, but there are also examples of people that smoked for a day and horrible things happened. The next one is that e-cigarettes are harmless to health. Emerging research shows that e-cigarettes can cause acute biological effects in the airways. Similar to those seen in traditional smokers, they may increase the risk of cardiovascular disease and lung conditions. Additionally, the vapor contains fine particles that can penetrate deep within the respiratory system. Like, I can't understand why people would want to vape, but like mentioned earlier, is that people aren't educated on these things. Nobody knows. And earlier this week, I noticed that what people are currently doing is to advertise it to the youth, is they're making the flavors appealing. And I understand how impressionable youth is, but once I saw this flavor that I'm going to tell you about now, I was convinced. You know, and that's just how bad it is. The flavor in question was bubble tea, matcha flavor. So that's a very popular drink. And so it's like a tea with bubbles in, and matcha is like a green powder substance they add to it. I just couldn't believe it for the life of me. Why would they create these substances and advertise it in such a way? Because they understand that the youth is moving away from traditional cigarettes, and vaping is the new future, and they need a new market. Because they understand that people are dying, and they need to secure the youth of today for long-term use. E-cigarettes are the most effective method for quitting smoking. So population levels suggest that e-cigarettes do not significantly aid in smoking cessation. Users often continue to use both e-cigarettes and traditional cigarettes rather than quitting altogether. Other methods have proven to equally be more effective without introducing new health risks. And I think that's a very important thing to understand, and that's a topic or a discussion we should have with our fellow neighbors, friends, anybody that is smoking. The new tobacco control bill will make e-cigarettes inaccessible to adult users. So, look, you're an adult, you can make your own choices of what you want to do. But our goal is to ensure that the youth don't take up the same habits. We went to several hearings, and one thing that stood out is that parents came forward and said they are smokers and they don't want their students, or rather their children, to take up the same habit because they understand how difficult it is to kick the habit. So what the bill does, it does not ban e-cigarettes, but it seeks to regulate their use, particularly to prevent uptake among young people and non-smokers. Adults will still have access to e-cigarettes. The regulations aim to protect public health without imposing complete prohibition. Well, obviously, the reality is at the end of the day, we would love to just completely remove it from South Africa. Next, e-cigarettes do not lead to traditional cigarette smoking. As a matter of fact, studies indicate that young individuals who use e-cigarettes are more likely to transition from smoking traditional cigarettes. This suggests that e-cigarettes can act as a gateway to other more stronger substances. And I spoke to Cornelia the other day, and she mentioned that normally when children start experimenting, they start experimenting acting, or what's the word I'm looking for? Yes. What their parents or people they look up to are doing. So they start by just holding it in their mouth, pretend that they're smoking, and from there it goes to cigarettes, and heaven can only imagine what goes beyond that. And then next, nicotine is not harmful. Nicotine is highly addictive. I believe the stat is 5 days and you're hooked for a very long time. And when heated in e-cigarettes can produce harmful substances like formaldehyde, and several carcinogens. And last but not least, plain packaging and advertising bans will increase illicit trade. And while the tobacco industry does argue that such regulations will boost illicit trade, evidence suggests that these measures effectively reduce smoking rates without significantly impacting illicit markets. These industries claim often lack of independent verification. So yeah, that's me, and I hope you can take this further, and I encourage you to do your own research, spend a bit of time online, see what people are saying, have a look at the data, and then be able to make an informed decision, and obviously carry the message on forward. Thank you so much.
I also want to just say, I'm sure many of you don't know the Cancer Association of South Africa. So just quickly, just a brief outline. So we are a national organization in all provinces. We are focused on research, educate, and support. So our education is training people, talking about the top cancers that affect people in our country. And then the support is what Abela touched on as well, which is the support groups, the tele-counseling. There's a lot of things that we do. We also have care homes where we have patients staying while they're undergoing chemo and radiotherapy. So in terms of, there are a lot of people here, I think from the People's Health Movement of South Africa, PHMSA, right, Tinashe? I hope I got that right. So we've been working together with Tinashe on the tobacco control bill, and we've got a lot of support from them. But what we want to do to the lady, sorry I don't get your name, what we've been trying to do is to try and get training done with y'all, with the team from PHMSA. So we were looking at virtual training. So during that we will cover the top cancers affected by people. So once we do training with y'all, y'all will be able to go into your communities and educate them on the different cancers. And what we can also do, Minenjle, is include the tobacco harms as well into that training. So I know I skipped my part here, so I was turn it over to Melissa.
Because it's you to thank.
Okay. Yeah, so Minnie, you want to say something?
I just want to thank everyone for the questions, just some of the responses that we got as well. But almost all the questions that were asked by people, I think they go to what Google raised, that in order to tackle this issue in our country, we need more than just education and awareness, but we're going to need what you call in social work a holistic approach to also try and speak individually. When we try and educate them, but we also need to speak with people, find out what is the root cause, besides the education, how to speak to individuals so that even after we share the education, we know that the people will now be equipped with enough information so that they can be able to say no to such things in future. And also just to collaborate, with other people as well, that not just focused on TC, but we see other gaps, other blind spots that we might have missed, in doing tobacco control.
Yes, I totally agree with what you initially said, and Gugu, just to also comment on what you said, I think in order to get to why people smoke, we need to get to the causes. And I think looking at what is the societal detrimentals to health, what is causing that. So we were in George where we learned that there's a program running currently in schools that's being carried out by Planet Youth. It's not sure. So they are actually working in 60 schools in Cape Town, where they are going in and educating the youth about the harms of tobacco. So we've been trying to sort of reach them so that we can work together, but we're going to continue trying with that. But I also heard that the government has invested in ensuring that there's going to be social workers at the schools. I think some schools already have social workers, but I think from CANSA's perspective, we're going to try and look at how can we meet with them and also include tobacco and alcohol and things like that as part of the school health program. So that can be done. But I also want to add to, in terms of the workplace, so Section 29 of the new Constitution says that every person has the right to an environment which is not detrimental to his or her health or well-being. So currently, the Occupational Health and Safety Act 85 of 1993 compels employers to provide a safe and healthy workplace, namely to make the workplace smoke-free. So that means every workplace should have a smoking policy. So if people are not sure, you can always contact the Department of Environmental Health or refer people to them so that they can check to see whether that company has actually got a smoke-free policy. So remember, public places are also supposed to be smoke-free public places. The new legislation is looking at 100% smoke-free public places. So in terms of the workplace, there should be a policy in place. We do get a lot of concerns coming through from our website and toll-free line, where you find people working in a small environment, like a little office, which is privately owned, and someone is smoking, and it's the boss who's smoking, and they are afraid. Yeah. So there's no public coming into that place, so they're afraid that if they complain, they will be fired from their jobs and things. But that's more in a private company. In that case, we try to look at how can we help. We get the department involved in cases like that. But where it's like a lot of employees, there should be a policy in there. So please remember to tell people about that. So now, people, we've come to the close, sadly enough. I've really enjoyed, and I'm sure my team have enjoyed today. So we really appreciate the time that you've taken out of your schedule on a Saturday. I know Saturday shopping, groceries, it's like cooking, it's the day that you get all of these things done. So we really appreciate your contribution at this workshop. It really has been so meaningful. We also know that some of you traveled at short distance and got yourselves here, so thank you for that as well. We also acknowledge the contributions of all those that have presented today at the workshop. I truly appreciate the presence of REAP, Professor Connie Walbreak, Sam, Dr. Sam, your presentation was really so good. And in absentia, also Dr. Vava, I mean, really, he's just so inspiring, and we really thank him for that. The Heart and Stroke Foundation, we really appreciate that you are here. Our volunteers from Mitchell's Plain, members from the People's Health Forum of South Africa, our survivors, and Abeda, thank you for bringing them. I think they are from Athlone, am I right? Our Athlone region. Thank you for that. Premier Hotel for their conferencing. And to our CANSA team, Melissa, Meninchler, Liaston was not here, my support person, Abeda, Ruston, and Meninchler, really, I know I gave you a sleepless night trying to put this program together. Thank you so much. Thank you.
Do you have a personal connection to someone affected by cancer?
Yes, I do.
Could you tell us a bit about it?
Yeah, it was my mother-in-law. She was affected, by stomach cancer. Yes.
My mom passed away cancer this years ago. That time we didn't have much knowledge of her.
I've got a sister who passed on in 2012. I'm not sure what type of cancer she had because she never disclosed to us. I think she was too ashamed, I don't know why. However, I finally found out afterwards from my other sister that it was stomach cancer.
My son is 51 years old. He contracted cancer when he was 25, and he complained about back pain. And the doctor every time just gave him tablets. On the end, he sent him to the hospital, and the cancer was now was stage 4 already. And yes, he survived. He survived. And by God's grace. And he's a strong man now. Overseas, yeah. And
That's amazing.
yeah. So there is help, yes.
And do you know anybody that's been affected by tobacco use or cancers that were caused by the use of tobacco?
Yes, lung cancer was my children's grandfather, because he was on smoking since the age of 15, and he died of lung cancer due to the smoking.
How do you think raising awareness about tobacco control can help in the fight against cancer?
Raising awareness is important because it gives one education and a freedom of choice. So I think for me it's very important for awareness to be out there so that people can make healthier choices for themselves, and that will ultimately fight the battle against cancer.
The awareness should be more, because young children, are buying cigarettes, especially at those spaza shops. And young children is being, prone to smoking because parents smoke. And they send the children for the cigarette. What we've noticed in our communities is while the child is walking home with a cigarette, not even burning, they are smoking because this is what they see. And it's a lifestyle that they see at home. And I think the awareness is going to be, more from grassroots level, even creches.
Raising awareness is of utmost importance, as most cancers are caused by tobacco usage. So it's very important that we need to go out, spread the word in our schools, in our communities, and to everyone. Because at the end of the day, if it's not cancer, it can be a long-term lung problem like I myself am sitting with. I never smoked in my life. However, I'm having all these lung problems due to secondhand smoking. If I knew back then that it's going to cause this type of damage to my lungs, I would have at all cost avoid being around smokers.
What are your views on establishing more smoke-free zones in public to reduce cancer risk?
I think that would be a very good idea because it would restrict those who are smoking. For some, if they can really kick off the habit, maybe they'll end up, slowly smoking less, or eventually just deciding not to smoke at all because of the environment not allowing them to do so. So I think that if it were to be completely limited, it would be a fantastic idea.
How effective do you think banning point-of-sale advertising will be in reducing tobacco use and cancer rates?
That would be a very good thing, because you see with the packages of the cigarettes is so entertaining. With our children, they like to see. So what they see, they do, but because of the packaging of the cigarettes, the colors of it attracts our young children to want to smoke. And also the advertisement of cigarettes and things, even on our TVs. It says don't, but our children want because it's literally advertising, for them to want to buy it, because it's the neon colors and it's the shaping of the boxes and all that. So I think that is going to be a good thing. Maybe they shouldn't put the color in the boxes.
And how important do you think it is to regulate and control the sale of e-cigarettes and other newer tobacco-related products to help reduce cancer?
I think it is of utmost importance. We know that when it comes to control measures and regulations, people very much don't like being restricted when it comes to certain things. So over time, for some people, it will become tiresome to try and keep up with what is relevant with regards to their habits, or sometimes they'll just get over it over time. So I think it would be a very good idea as well. I think it's very important, in fact, that you'd have strict rules and regulations against tobacco sales.
What message would you like to share with those currently battling with cancer? And how do you think tobacco control measures can support their fight?
You know, the message I would bring out to somebody that's already, you know, he shouldn't have started smoking maybe in the first place. But, you know, it's like early detection saves lives. It would be you see, because on the packaging there is warning signs. But it is being ignored by our communities. Even learned, educated people, you know, they also read what smoking does. But it is not being taken seriously. But I think the laws must be more serious, you know, in implementing like more stricter rules. If we see somebody going by, you know, the law must be enforced. The law is not too strict on these things as we wanted to do. And I think it will save a lot of people from ending up with cancer if our laws can be implemented more strictly.
The measures can support their fight because it basically gives them hope that from what they're battling with, they have something that not only the government, not only people that they love supporting them through being there for them for their cancer, but also like they'll know that there are regulations to try and prevent it for the next person. For people fighting cancer, I would say that it's not a death sentence. I know that some things can be so hard that you experience, or it's easy for the next person to say it's not a death sentence because you're not going through it. But I do believe that you will never be given a task you cannot handle. You just need to keep a positive mind and also remember that it doesn't end there. So you want to live to tell the tale that I went through this and I beat it, so that the next person can also live from your story. And I think that's a beautiful thing to be able to being impactful for the next person.
To look after themselves, to really focus on just getting better. And just to encourage them. Yeah, I don't have much info.
No, that's wonderful, because the thing is, you're mentioning pretty much everything they need to do is like focus on their health, you know, eat healthy, stay healthy, exercise, and just be mindful that what they have is, you know, isn't the end of them, but it's something they can fight, and there's a support group around them,
Yes.
like yourself being a part of them, and just having someone to speak to about how you feel makes a massive difference. And that's something that shouldn't be overlooked. You know, just having a shoulder, just, you know, just to lean on, just to cry on, and those are very valuable.
What I would love to say to those battling with cancer is that cancer cannot cripple love. Cancer cannot shatter hope. And cancer can most definitely not conquer the spirit. So there is, after this difficult road, there can be a beautiful destination. So life is 10% what happened to us, and it's 90% how we react to what happened to us. So there is hope beyond cancer. And every day that you open your eyes, it is a little bit of hope to recovery, or a chance of recovering. So all those who do have cancer, remember that you are strong. And I always believe that God gave his toughest battles to his strongest soldiers. So just remember that you are not alone. We all stand behind you. And we believe that nothing is impossible with God.